So conflict of interest, I've had a lot of lunches from a lot of companies, but I've not been a consultant to any company. I've had no meals from Epic. They don't believe in even providing meals. So when I talk in spring, I show this picture. This is Washington, D.C. If anyone has not seen the Cherry Blossom Festival, you should see that. It's beautiful. So at least you start thinking about this in the winter so you feel better. So if you look at the anesthesia information systems, there's a sudden increase in the implementation in the last 2 to 3 years. Anesthesia information systems have been around for 25 years. We have had them in CHOP. It was installed when I was a fellow in 93 to 95. We were one of the first in the country. So when you ask vendors, as a part of the society president, we ask, how many clients do you have? Everyone lies. They say that they have 250, 300 clients when there's no 300 sites having anesthesia information systems in the country. So this is a nice company that does independent data research. So the class group is not-for-profit group that you can get reports. If you give them data, their reports are free. Otherwise, their reports are like $8,000. So if you look at the class report, these are all the major players. Philips is the one we use. Pisces is the one they have next door. And Epic is still not in there. Now, as part of the Society for Technology in Anesthesia, we did a research project looking at what the installations are and what do they do. So the information we got was, these are the major players, and most of the data capture is intra. In the post-op, some of the systems are doing it, and here you see Epic. So people have started using Epic in the post-op period for notes. And they're still in the early period of installation still. Now, if you look at the major installs, they've all been within the last 2 to 5 years. I think the new fee-for-service and the money that's being given out to information systems by societies and federal government is promoting this. Although anesthesia information systems per se is not getting any money. So if you look at who has information systems, it's mainly the large hospitals. Hospitals that have more than 50 operating rooms tend to have it. And these are small groups. Most of the private practice small hospitals do not have it, and the projections are for the next 5 years, they will not have it. So what is AIMS? 2 years ago, we got a group of people, because anesthesia information systems used to be called anesthesia information systems, anesthesia information management systems. There are several names. So the group joined together and came up with the terminology AIMS, because I'll show you what it is. So who is driving this? There's one super user in every hospital, like at CHOP, it's going to be me or David Cohen. Every hospital has a super user. They're driving it. For some reason that I don't understand, in anesthesia and ICU, a lot of the physicians are not trained in informatics. In pediatrics, we have a lot of people who are formally trained in informatics. In anesthesia and critical care, they don't have formal training. So if you look at what is AIMS, AIMS is a system, it's a repository of data coming in from the chart, which is your main intra-op and post-op data, QA data, billing data, research data, residency data, evaluation privileges, and others. Others is any data that you can push into the database. So this is one of the oldest AIMS. So what it did was, this is an anesthesia machine, and here it records your data. And this is what we had for a long time. This happens to be our downtime policy too. So we call it the E-policy. And this is the system we use today. It is, the system that we use is a thick client self-standing system. We'll go over that a little more later. So challenges in data collection. So vital signs, we've gotten very, very good at collecting vital signs. Over the last 20 years, we have learned how to do it and done it well. Like when we go to Epic, when we go into the vital sign collection, it's going to be a problem because it's going to take time with the interfaces and everything. But Anesthesia Systems has been doing it for 20 years. We have learned to do it well. So this is a case that we had where we saw changes in the operating room first. This was a spine case. And then we realized that the spinal monitoring had a problem. So we combined the two databases. We realized when exactly the time that the physiological changes occurred, the patient lost his potentials in the lower limbs, which means essentially he was paralyzed. So the first capture of a major event was here. So actually this was published this month as using anesthesia information systems to collect vital data. So when do we have problems? When we have new equipment, new hospital software, and remote location. These are major problems that we always try to fix. So here's an example. We got new machines. The vendor told us it works. CompuRecord told us it works. When we started recording, we have no vital signs. So we went back and asked the hospital that had it and had CompuRecord. They said, no, we've always had problems. So what the lesson we learned was call a hospital that has got similar software and similar equipment. Another example here, we got new anesthesia machines. We don't use halothane anymore because halothane causes hepatitis. But when we go to our database, there's halothane there. So the machines are recording wrong data. So the lessons we have learned is simulation, call hospitals with similar setup. So we run the equipment for 3 or 4 days, we look at the database and make sure we have no problems. So we use wireless technologies and tablet PCs. We were one of the first to use tablet PCs. We wrote a white paper for CompuRecord about 8 years ago. But we started using it, and the nurse practitioners who were using it stopped using it because they said it gives them back pain. I think now with the iPad, they may start using it again. So what are the other challenges? Off-site challenges, we send anesthesia teams across the street to the Penn Radiation Center for XRT, oncology clinics. And in MRI, we use a wireless solution. There's a monitor inside it, 802.11, the data is sent out. So patients in other hospitals, not only in this country, maybe in another country. Here's an example of what we did. We monitored patients in real time in India. So here is one of my partners saying, what the hell am I doing? Because it was the reverse of outsourcing, which means we were up from midnight to 8 in the morning doing these cases. So we had 3 cases, 3 days, and then we had to come to work on Monday. So essentially the system that we have in the operating room, we can connect it to another OR and get data feeds. So this is the field. The picture is not clear, and that's the data that we got. So we were trying to interface the monitors, but we could not do it. One of the reasons was it was too short a time to test the interfaces. So the best we could get was a handwritten record. And to date, this is the major telemedicine case for a major surgery. So anybody talking of telemedicine for major surgery talks about our work. So the things we learned was connectivity and integration of data. So one of my friends from the Society for Technology in Anesthesia is starting the Plug and Play initiative. It started off as a small project of our society, and now is a major project with federal funding and state funding. So what they're trying to do is, like, you can take a thumb drive, put it into any computer. You can take any monitor and plug it into any information systems. So the plan is, in the next 5 to 10 years, there should be a plug and play option. So this is the group that's doing it, and Julian Goldman is the person out of MGH who is running it. So where are we today? Data capture is very good. Artifact diagnosis and deletion is getting better. And decision support is still in its infancy. I think decision support across medicine is still in its infancy. The person who did a lot of work on decision support is Dr. McDonough from MGH, is now in Indianapolis. He gives a good example. He has this patient in his hospital who's brain dead. She's a lady who's 35. So the decision support pops up and says, do a mammogram and a pap smear on a dead patient. So decision support is still a long way to go. So new hospital software. I think there are problems with that. So this is CompuRecord. This is OR Manager, and this is Epic. We have a three-ring circus in the operating room. So when everybody talks of HL7, any vendor comes to the hospital, he says, oh, we are HL7 compliant, we can exchange data, no problem. Or the other word they use is CCOW. So we are CCOW compliant. CCOW means that you can start a software from another software. So on Epic, there'll be a little icon of CompuRecord, so you can launch CompuRecord from there. So it looks like one software, but there are two programs running. So any vendor you ask, you say, oh, we are CCOW compliant, HL7 compliant. What does that mean to me? I learned it after this big assessment we had. We spent a lot of time trying to get Epic and CompuRecord to talk. And this is what we learned. That's essentially wasting your time. HL7 and CCOW means nothing. So the other thing that we have not done at CHOP is getting industry money. We have not been very entrepreneur in getting industry to partner with us. This is Live Data. Live Data got a grant and they wanted to build a dashboard. So they took their money, went to MGH and said, we will build a dashboard and the dashboard is going to be free for you, but then we're going to sell it to everybody else. So essentially what they take is they take information from their different systems and put it on one OR dashboard in the operating room. So you know everything that's happening. So in our OR, we could put CompuRecord, OR Manager, and Epic on one dashboard. So quality assurance is another thing that we have spent a lot of time and money in our department building our homegrown system. What happens is at the end of a case, there's an option to indicate whether there was a QI problem or not. If there's a QI problem, there's a check done. It's a self-report system. And then an email is sent off to both the QI department and to the people involved to fill out a form. And what happens is this is a self-report data query and reported by staff, and any other provider, like a nurse or a nurse practitioner, can fill out without the permission of the attending. So it's an open system. So this is how you go in, you fill it out, and you find your case, you report. This is a homegrown system that was built by the Ping group. And then we get our summaries at the end of the month. So what we can do is we can look at summaries like this and look at every month, look at the data and see if there's any change. Is there more problems this month, or is there new problems? so we can do run charts and see what the problems are. Now we know that manual data is flawed, so handwritten data. So here is a study that was published in 2000 showing the same case, handwritten chart and computer chart. When the blood pressure is less than 100, the 10% captured it. There's a difference here. 1,000 cases of blood pressure changes, only 431 captured it. So we know that manual charts data is not good. Computerized charts, the data is very, very good. So there's another study showing text data. When there's a problem, about 64% of the times they capture it. What did we see in our research? When we looked at it, we looked at a study where we had 1,000 cases. There were 8 episodes of emesis. Only 2 were documented. So if you look at text data, it's essentially garbage in, garbage out, and only 25% is well recorded. On the other hand, the vital sign hard data is very good. So a lot of hospitals run automatic QI. What they do is they look at blood pressures and see who's having the most amount of hypotension, and they can give out automatic reports. We cannot do this in pediatrics because the blood pressures are not standardized. And that's one thing I wanted to ask your group. Yeah, you and Jeff to help us to do data analysis to set up pediatric blood pressure norms. So Dr. White is going to help us with that.
Okay, we'll talk.
Okay, which means no, huh? Okay, so the QA data that we have is the QA team knows who all has problems. We've had a lot of discussion about this. The administrators have asked us for the QA data to use it for hiring and retaining and firing, but the QA department has said no. Because if you start using the QA data for firing people, nobody's going to self-report. So it's kept on a department server and secure. I show this because this is money. Okay, if you don't get money, there's somebody in your department who's going to go after you. So we use CompuRecord for billing. So there are a lot of vendors that has a lot of interest in AIM systems now, and are building interfaces. They say, okay, tell us which anesthesia information system you have. We have interfaces to them. So essentially what you do is the coding can be done in the OR. It's automatic capture modifiers. Anesthesia billing, unlike pediatric office billing, has got too many modifiers like A-line, hypotensive technique, hypothermic technique. So all these modifiers can automatically be captured by a good system. And then it can be sent as a flat file or a direct interface, and the bills can be printed out right away. So there's been studies when you go and try to get an anesthesia information system, the hospitals usually ask, is there a return of investment? The studies have shown that there's a one-time increase in revenues, and that is the return of investment. I like this slide very much. I learned this in school. If you look at all the data that we have since '99, this is in billions of gigabytes. It's been increasing. But look at the human brain. That has not changed. That's been pretty consistent. So we got a lot of garbage up here. I call that the Google syndrome, but the brain can only capture so much. So what we have to do is we got to take all the data that we have, make it into good information, and give that as knowledge. So any organization that's strong has got a very good knowledge base, and you won't keep reinventing the wheel. One thing that we have learned with the Epic experience is we reinvented a lot of wheels. I like this picture because if you look at the Washington Monument and take a picture now, with higher density of data, you see that there are two different colors up there. Anybody knows why? It's $1.
You stopped building it during the Civil War.
Very good. So they started building that, and then the recession. They stopped building for 25 years. If you look at an old camera and your old digital camera, you cannot pick it up. But with the new cameras, with the higher pixel density, you can pick it up. Oh, you're $1.
Cherry Blossom Festival.
Okay, so what did I learn from my travel to India? So I got a text message from MasterCard, and MasterCard was shut down. I recently went to India. On my trip, my MasterCard got shut down. I got an email from American Express. American Express was shut down. And my ATM, luckily they gave me a phone call and didn't shut it down. So what does this mean? All these companies have databases and they're running risk analysis in real time. That medical industry is way, way, way behind. We do not run risk analysis in real time. Another example of data relations is this. Whenever the economy has tanked, the Phillies have won. That's a scary thing because we need another recession before they win again. So what this just means is you're taking two relational databases, relating them, and coming up with conclusions. So why can't we do this in medicine? When we set up our data model about 5 years ago, we set up a data warehouse for CompuRecord. I went to the company and asked, do you have a data model? They said it doesn't exist. Does Epic have a data model? Do you know, Tony? For general, how to set up their data and?
They have a model system, but.
Okay, so I'm not sure if they have a data model in which they run standard queries in real time. So I think one thing that's lacking is the data models are building. And I think there are a couple of companies that are going to come in big time. Oracle is coming into medicine, and so is SAP. Once they come in, they're going to bring in real world experience to medicine, and we will have real-time queries. So if you look at data modeling, these are tables that make sense. Okay, we need to have tables. One of the things that we should do, if Epic is smart, they'll do, is the tables across all the pediatric hospitals. If they're similar, we can exchange data. But unfortunately, they're not. One of the experiences, they got Epic in Portland. There's OHSU and Kaiser. Each one has 3 million patients, and they can't exchange data because their tables are not similar. So when we started setting up our data warehouse, we asked them for data flow diagrams so that we can have concise physical and logical levels of data and to develop our own data model. CompuRecord did not have it. And I talked to other vendors, and nobody had it. So conceptual model. I think one of the things that we should do when we set up our data warehouse here for Epic is first develop our conceptual model. Try to see what the physician wants, just get their wish list, and then go in and build the physical data model. So that if we do it right and do it well, maybe we can sell our data model to other hospitals. So process modeling, one of the common process modeling they do with AIMS is the billing module. So what you do is you take a complex billing system and then you make it into sub-processes and feed the sub-processes in so that you can get your billing system in order. So one of the problems we have is here. We got a lot of garbage data. We have about a few thousand patients by the last name of test. So we don't know if that's real test systems or is a patient's last name is test. It's just like Hope lives here, and if you have the last name Hope, it's a bad thing. So We have our data warehouse. We try to clean up as much as possible. I, um, we think that our data may be 98% clear, and we use it for all this. We online analytical processing, data mining, and reporting. I'm going to go through a few of the things that we have done with our data. So our data warehouse has billing data and AIMS data. And because it's a relational database, it's a SQL server, we can relate it to any other relational database. We have greater than 200,000 cases. Ours is the largest data warehouse for pediatric anesthesia in the world. Nobody has so many data, so many cases in one place. So what we have is pre-op data, post-op data, case data. We can link it up to QA data, and we can link it up to the procedure and diagnosis data. So one of the first studies that came out of CHOP, literally one of the first safety studies that came out of anesthesia information systems was from CHOP. So what it did was they looked at this drug and the risk of bronchospasm. They found the patients who got rapicuronium had a much higher incidence of bronchospasm compared to the non-drug users. So what did it do? It pulled the drug off the market. This was the study that literally pulled the drug off the market. So the question is, we know rapicuronium causes bronchospasm. Why can't we run queries in real time that tell us, guys, we have a problem? So if we can run queries in real time and relate drugs and bad outcomes, maybe it will help us in the long run. So craniofacial studies, Paul Stricker is one of the anesthesiologists. He's used this data, and we made a lot of clinical changes for day-to-day management of patients based on the data. So what we did was it started as a retrospective study, and it's now a prospective registry. So what we do is if you're starting a registry, we get IRB approval ahead of time so that we don't need to keep going to IRB every time. So we looked at historical data. These were all the problems. Then we went to our data, and this is what we found. There was no intraoperative death, one intraoperative cardiac arrest. And then we looked at product utilization. So we looked at RBC, FFP, platelet, and cryo. And we came up with some data-driven conclusions. So whenever you use intraoperative FFP, the postoperative coagulation was better. And postoperative blood transfusion was less. On the other hand, if you use albumin, there's a higher problems with coagulation. So how did this change our practice? Once we got this data, we don't use albumin anymore. So a lot of people across the country don't use albumin anymore. It's based on our data. And the other thing we saw that intraoperative FFP improved post-op coagulation, and patients received FFP. So we said, why not all patients receive FFP then? So what we do now is we use reconstituted blood. We take a donor's whole blood, we divide it up into packed RBC FFP, and use that by reconstituting it. The other thing we saw was when we started reconstituted blood, it reduced donor exposure. So children are exposed to less blood. So this was all based off the data we have. And once we started the new practice, we saw that their coagulation profile was better. So here's an example of using the data to improve patient care. The other thing that comes up is, by improving patient care, are we improving outcomes? That's a bigger question. It's very difficult to answer because the morbidity and mortality in anesthesia is so small. The other example was preventing surgical site infection. One thing I learned from this is at CHOP, many people are doing the same thing in parallel with one group not knowing that another group is doing this. When I got involved, there were 4 independent groups looking at the same thing, not knowing that there was some other group doing this. So finally we started looking at data, and what we did was, the goal was to give antibiotics and reduce surgical site infection. So we wanted to make sure everybody got the first dose of antibiotic and the second dose. So we got certain antibiotics as our markers, with cefazolin, metronidazole, clindamycin, gentamicin, vancomycin. The initial dose had to be given within 60 minutes, and the second dose had to be given within 4 hours. Initial data. This was our initial data. 30% non-compliance at the first hour, 83% in the second for the repeat dose. There was a little improvement in this, but not much. And then we looked at this study that was done in New York. What they just did was putting in a decision support like marker, like it said, please give antibiotics or check if antibiotics. Then Larry set up another template showing whether antibiotics were given or not. Putting these two things in place, this was the change. Now, actually, this is less than 10%. A lot of this 10% is people have forgotten to document. The other thing that we have looked at is, at our liver transplant patients, we have looked at the inotrope use. So looking at dopamine and epinephrine. So we were surprised to see that there are 2 types of children who come for liver transplant. One is the healthy, who come from home. Another the group of children who are sick in the ICU. The healthier the patient is, the more difficult it is to manage their anesthesia. So if a patient comes from home, it's more difficult to manage because they don't have certain problems which are easier to manage. So we looked, that's called portal hypertension. So if they have portal hypertension or no portal hypertension, dopamine use is the same. And then when we looked at their epinephrine use, we found that the healthier children had more epinephrine use. There was some opinion on this, but we got data. And another study that we have done is this, is children whose heart rate slows down significantly on induction. So this is the normal heart rate, and this is the heart rate slowing down tremendously. This is a Down syndrome kids, and this was published last month. And all the studies before, the data was from handwritten charts. So you know that handwritten data is useless. So this was the first study with computerized digital data. So what we found was, whether you have heart disease or you don't have heart disease, your bradycardia is pretty similar. There was one new thing that we didn't know before. And the second thing is, if you have Down syndrome, you have a 60% chance of getting bradycardic during anesthesia. The other thing that we have been looking at but have not done a lot of work is the blood utilization. The goal is to get all this blood utilization data that we have for almost 10 years and make a iPhone app. So if you put in the procedure and diagnosis, it'll tell you how much blood you may need and how much blood to order. Because these data is available for adults, but is not available for pediatric use. So this is something that we are working on, and hopefully within the next couple of years we'll have that. So how quickly can we get an answer? We had a group of people come back from a meeting and telling that Noonan syndrome is prone for MH. Lisa manages all the data. Within about 5 minutes, she pulled out all the Noonan syndrome and said, no, they don't have MH. So within 5 minutes, you can get answers to questions that we took a very long time in the past. And this is another thing that we need to keep in mind while we are building EPIC, is building fellows reports and residents reports. because if you don't generate reports, the residents are never happy, telling that they're not doing the right, either they're doing too much work or too little work, and they have to log their hours. So we've got to build reports while we build our information systems. The last 10 minutes I'm going to talk about the future. One of the things is we got applied genomics. We got a large genomic lab. Can we use the data to see if there's any change in anesthesia day drug utilization? So one of the studies that we are doing is we look at morphine. When children come for TNA, children can use anywhere from 0.05 milligrams per kilogram of morphine to 0.25. That's a huge range. And there's some children who are getting 0.3. So what we're trying to do is there a genetic marker which will tell us if they're a high morphine user or low? So we are combining the anesthesia data warehouse data, the genomics data, and the pharmacy data, and trying to see if there is any markers that we can come up to predict high users or low users. The last study that we have been doing, which is pretty interesting study, is anesthesia emergency. So whenever we have an emergency in the OR, we call it anesthesia now, which is essentially like code blue on the floor. So we looked at our data warehouse, and for the last 5 years, we are 23 anesthesia now. That didn't make sense because 1 for every 4,500. So we said, okay, we're going to put a tab where at the end of the case, if you had anesthesia now, you're going to check. You're going to just touch it and it's going to. So the next data that we got was the real incidence was not 1 in 4,000, but it was 1 in 400. So just changing a little and making it easier to capture data can improve your capture. And then we are looking at what events cause this. I'm working with a couple of groups. The thing that I'm very interested in is doing projection models, just like the credit card companies do. Can we predict these problems before they occur? That's difficult but possible now that we have good data. So what we're doing is taking, whenever there's anesthesia now, we go back and look at the data and see if there's anything that has changed. And a lot of times the problem has occurred 5 minutes before and is just deteriorating. So we're looking at personnel. One of the things that we're seeing is if there are a particular group of younger attendings, younger residents, there's higher incidence, which make common sense, but we have data now. And to see based on this data if we can predict a problem before it occurs. Then we're also looking at personnel, if there's any change by if there's a particular attending, particular nurse, or a circulator, is there a delay in the rooms. This is a very touchy subject because everybody says it's not my problem, it's somebody else's problem. I'm going to leave you off with some national things that are going on. The MPOC group is a multi-center perioperative outcomes group. It's one of my friends who started this. And what they're doing is they collect data from every hospital. They have close to 2 million cases. So some problems which are very low incident case can be picked up from this, like epidural hematoma after doing an epidural for pain block. And one of the things is you can send their data, anybody can apply for an IRB for any study, but you only get the data back if you have provided them with at least 25,000 cases. So you'd say membership type of thing. So they have all this data for close to 2 million patients now. The last thing is the AQI group. My group, which is from CHOP, is leading this national group so that all pediatric hospitals across the country have the same data for outcomes, for difficult airway, and for craniofacial. Because that's a difficult thing because each group has got their own data which does not make sense. It's got nothing to do with HL7. It's got nothing to do with ICD-9 or CPT-4. I don't know where these names come from. So the AQI, which is the Central Anesthesia Quality Institute, is supporting our work. So what we will be doing is, we are the subspecialty society, which is the Society of Pediatric Anesthesia, and CHOP is leading this effort to bring about the quality markers. So last 5 minutes, I'm going to talk about AIMS and the network solutions and the problems we have learned. So this is not unusual. We see this sometimes. Emails about systems being down sometimes happens. In summer, everybody remembers the whole system went down, but CompuRecord continued to work. Somebody's got a network problem. So why did it continue to work? One of the reasons, I'm going to show you a schematic. So whenever you go to ECMIS, this is the report you get, network uptime 99.5%. But sluggish network activity, application downtime are important variables that we need to know. And downtime policy, we hardly ever go to this. We rarely have to use paper. The reason is the AIMS is an independent full client system. ADT from Epic feeds AIMS to give the basic ADT information. The physiological data comes into AIMS, and the CompuRecord AIMS system sends out the record and can print it. So even if the ADT is down, which is Epic is down, or the monitors are not communicating, we still have the system working. One of the problems when I first went to Epic, when they started this Epic Anesthesia Information Systems group, I told them it has to be a thick client. One of the answers I got from them is whenever Epic goes into a hospital, the networks don't go down. So I told them, I don't know what you guys are drinking, I need some of that. Because networks will go down, irrespective if it's a new hospital, old hospital. So they need to come up with some solution when this connection and this connection. The way Epic system works is the physiological data and the ADT data comes from a central system, and this is a thin client, which means if there's a problem here, a problem with any of the connectivity, the system will not work. So after I met with them and after several other physicians talked to them, now they've got something called a capsule capture. What the capsule capture does is it keeps the data for up to 5 hours. And then if the system comes up, it'll push the data. So it's not a thick client solution, it's not a thin client solution, but it's somewhere in between. So an ideal system would be network independent. The monitors send data directly to AIMS, but most of the systems, the monitor data goes from a monitor to a central monitor server and then goes to the AIMS. So if we set it up, it's going to go from our monitors to a GE server and then to the Epic. And application redundancy, which is easy to talk but difficult to do. So what does work for us? Thick client. Our downtime is minimal to none. Physiological network independent data and local and network print capability. Because if you don't have a system that works, this is what's going to happen. And pay for performance is a big thing. We've been working on it. I think the cardiac group was the first to start it, and there are a lot of new things that we have been doing. Thank you.